Uh, Good evening, everyone. I hope all of you are able to hear me. Welcome, Dr. Bapi Raju. We are still waiting for a few participants.
Yeah, thank you, Rajesh. Thank you.
I am just going to put a message in the button. Okay. So, Dr. Bapi Raju, we arranged actually this FDP actually on a very short notice. Like actually, we had a very little time since the AICTE gave approval, but we had almost 117 or more than that participants actually registered within a very short amount of time. It was so
Right.
yesterday
Yeah.
we had the inaugural session.
Right.
So we had Dr. Chinmay Chakravarti from Birla Institute of Technology in Masar, and we are going to
From
have
where?
from bits master from in Orissa, I think the one of the new bits.
Okay, bits. Okay.
Say, everyone, please. I think I will have to mute participants. So everyone who is please mute yourselves. Like just just. Yeah. Okay. Yes. I think everybody has been muted. Okay, so we we are getting short on time. There are a few more participants are supposed to join, but I think I would start introducing Dr. Bapi Raju to everyone. Um, is my voice audible to everyone? Please write in chat. Um, and chat is also for, like, whenever you want to ask questions, you can do that. Okay. So, yes, good evening to you all. So, uh, to introduce uh, Professor Bapi Raju is a great pleasure of mine, because he has been my PhD supervisor, and most likely my philosophical guide for almost now more than 16 years. Professor Bapiraju started his journey as an electrical engineer, uh, but he, while working in fact, in Bhopal and other places, he wanted to get into interdisciplinary studies. So he went to University of Texas Arlington in USA to do work on biomedical engineering, where he got involved into a computational modeling of the brain because of his supervisor there. And then he correspondingly did his PhD. And then following that, he did two postdocs, one in UK, one in Japan, with again another eminent personality in neuroscience and computer science, Dr. Kenji Doya. And following that, he was one of the people who had started this school of computer science. Like, computer science existed, but AI block and other things became much more prominent in University of Hyderabad, or Hyderabad Central University, following his joining. And he is also one of the founding members of Center for Neural and Cognitive Sciences, where he was the coordinator for, while I was his PhD student from there. And following that, he has joined IIIT Hyderabad, um, where he does interdisciplinary studies along with quite a few machine learning and other people. Uh, Overall, his work is completely interdisciplinary. It is not just engineering, not just neuroscience, or even psychology, or biomedical sciences. I would say that his work kind of has laid a foundation which will be probably recognized in quite a decade of time. His most important achievement is making cognitive science a viable study or method in India. In fact, he was also twice the secretary of Association of Cognitive Sciences, founded in India in 2014. And he has he has shaped a lot of minds throughout the years, over 35 years of his career. But most often we remember him because of the encouragement and the kind of guidance he has given, not only to his own students, but students across different disciplines. To that end, I would now invite Professor Bapi Raju to give his talk.
Right. Yeah. Thank you, Rakesh. It's a wonderful introduction. Yeah, I welcome you all to this FDP, an interesting topic, which interestingly, it's not exactly cognitive science, but applications in health technology, how AI can make a difference to health technology. This is what currently I'm also focusing on, apart from other threads in research. Just wanted to see how many of you are engaged in machine learning or something in healthcare currently. If you are, just type +1. If you are currently looking at healthcare applications. And yeah, so uh, quite a few people are looking at various. Anybody looking at sleep quality assessment and things like that? Type +S. Yeah, so today I'm going to talk about some applications we looked at in sleep quality assessment using electroencephalographic data. I'll try to make all this clear as we go, and I'll give you one case study of a deep learning application for automatic sleep stage classification. Let me share my slides. Yeah, I think Rakesh, this sharing need to be enabled for me.
I've allowed, sir.
Right, right. Right. So yeah, full screen. Uh, yeah, so you can see my slides, right?
Yes, it's visible, sir.
Yeah. Right. And also just to get an idea, how many of you are, uh, computer science? If it is computer science, C, you type C. If it is ECE, type EC. If it is electrical engineering, you type E. So yeah, we have, looks like have mix of audience consisting of both computer science and ECE. Okay. Yeah, so EEG based sleep quality assessment deep learning solution is what I'm going to look at one solution. So this is work carried out by my master student Swadeep Methi, who just graduated and joined a PhD program in UC College London. So it's his work that we did jointly that I'm sharing today. And my affiliation here on the left-hand side, you see, I have data, which is what the sponsor of this work. This is a technology innovation hub set up by Department of Science and Technology at various institutes, around 20 or 25 such technology innovation hubs have been set up all over India. At IIIT Hyderabad, most of them are in one of the other IITs or ISC or ISI, Bangalore. The only non-IITs are IISc, ISI Kolkata, and ISM Dhanbad, and IIIT Delhi and IIIT Hyderabad, and BITS Pilani. So these are the other hubs. And the mandate for IIIT Hyderabad's hub It's called iHub data. The mandate here is to collect large-scale healthcare data sets to jumpstart AI model development for variety of tasks. It could be diagnosis, screening, or treatment related, patient management, emergency room, any of these applications. So the idea is that modern machine learning and deep learning solutions require quality and quantity of data available for these solutions to uh, be designed and learned, tested, validated, all of this. So as part of this hub project, we had a collaboration with NIMHANS, National Institute of Mental Health and Neuroscience, Bangalore, where we looked at sleep EEG data from stroke patients. So I remember in a previous FDP, I talked about some applications we developed on ECG. So today I'm talking about EEG-based solutions. Okay, so today I'm going to talk about briefly about sleep disorders, the architecture of sleep, and polysomnography is a gold standard for sleep data. Then wearable devices, and one solution is EOG-based sleep stage classification, which is what is the heart of this presentation. And the last one, there is a data set that we created with the help of NIMHANS. I'm going to give some idea of this iSleep data set and the future scope in this. This is what is the plan for the next 1 hour. So you can type in your question anytime you have. I'm monitoring the chat, so I can stop and react to your question. So sleep and sleep disorders, let's look at that first. Right, I mean, I don't need to emphasize sleep is very important. It's a complex biological process. It's essential for life, and it's crucial to our health, as crucial as eating, drinking, breathing. It's just like these, sleep is important for our physical and mental well-being. Right, I don't need to emphasize, just but for completeness, I included it. And benefits of good sleep beyond restfulness, it also is important. Modern neuroscience investigations have shown that it's important for brain function, especially learning and consolidation is mediated or is effective during sleep, right? And it has been shown that sleep deprivation causes memory related disturbances, encoding or retrieval, all these are impacted by lack of sleep. This has been demonstrated in both in animals and humans. Specific experiments that have been conducted by neuroscientists to verify this. And our immune function is intact. Immune function requires good sleep, emotional well-being, physical health also is the lot of bodily functions, repairs of the body, all that happen during sleep, right? So this is the visual about learning, consolidation during sleep, and retrieval. It has been shown that slow wave sleep is related to or is associated with memory consolidation. Consolidation is the process whereby whatever you experience during the day as part of your learning epochs, all that is consolidated, is rearranged and brought together and that property and that function is related to slow wave sleep. How does one know? They have done experiments where with the permission of the participants, they monitor the sleep EEG, and slow wave sleep is the the deeper end of the sleep cycle. When the patient goes into the deeper end, they wake them up, right? So that's what is shown here. And I'll show you a hypnogram. This is called a hypnogram. This is a collection of what kind of stage the person is during the sleep cycle, the sleep experiment. So during the deeper end, they wake them up, and so that they don't allow them to go into deeper. The slow wave sleep cycle is disrupted. There is after waking up, they do a retrieval. They give a set of things to remember, and this retrieval gives you an idea how much they have remembered. Right. So the retrieval seems faulty if slow wave sleep is disturbed. So that's how this experiment goes, and it has been shown and replicated several times. So we know now that memory and sleep are tightly coupled. Apart from this, the sleep disorders, right? The normal function requires a good amount of sleep, and people who have difficulty sleeping, insomnia, difficulty of falling or staying asleep is a disorder. Sleep apnea, these are different kinds of sleep disorders. Breathing interruptions during sleep, restless leg syndrome, and irresistible urge to move legs and resting, narcolepsy, overwhelming daytime drowsiness, and sudden sleep attacks. And all of these are sleep disorders, and they are related to disruption of the sleep architecture. So we are talking about sleep architecture. What is this sleep architecture? Right? We look at sleep cycles in the next couple of slides. Um, so sleep is broadly put into these different stages. W is the wakeful stage, where the brain rhythm, the frequency at which the neural firing happens, is typically in the alpha beta range. Alpha range is 8 to 13 hertz, beta is greater than 13 hertz. This is the wakeful sleep stage. In the first stage of sleeping, N1, this brain is at theta rhythm, 4 to 7 hertz. Typically, in N1, participant spends 5% of the time. N2 is where you have different signatures of sleep, K complex, sleep spindles, and the general rhythm is 12 to 14 hertz. Is 50% of the sleep quantum is in N2 stage. N here stands for non-REM. REM is rapid eye movement sleep. The rest of them are named non-REM stage 1 to 3. Third stage is delta wave, the low frequency 0.5 hertz to 2 hertz. High amplitude, low frequency sleep, this is 20%. And this is where a lot of, this is very important sleep stage for getting the best benefit of sleep, deep sleep. And REM, rapid eye movement sleep, is a characteristic that's found both in animals and humans. And we still don't know what is the function of this, but I mean, a clear idea of what REM or rapid eye movement sleep, as the name implies, during this stage, the eyes are closed, but there is eye movement that is noticed. This is in theta alpha range. This is 20-25%. So maximum amount in non-REM stage 2, and the remaining REM and deep sleep are around 40-45%. Now, sleep cycle, and what is the sleep cycle and micro structure. So this is the alpha wave, relaxed wakefulness. wakefulness, and the stage 1 is theta wave, stage N2 is spindles. These are not of activity or K complex, this K-shaped sort of waveform that is observed in stage 2. Stage 3 is the deep sleep, where the high amplitude, low frequency, very slow changing waves, delta waves. And then REM or dreaming sleep, you see this is somewhat similar to the wakeful type of stage, where this activity has this kind of profile. So what so it's a cycle. That means it is N1 goes to next stage, and things like that. So so the first stage between wakefulness and sleep, just getting into sleep, that is the, and then you move to stage 2 after around 5 to 10, 15 minutes. Heart rate slows, brain does less complicated tasks, and it's, so another 15 minutes or so, you go into non-REM sleep, N stage. Body makes repairs is the stage, and the next stage, body temperature and blood pressure decreases. Then you move into REM sleep approximately 1.5 hours after the first time you felt sleepy. You go into what is called REM sleep, where there is increased eye movement, and also the bodily functions also increase. Heart rate, breathing, BP, temperature, all of these also rise. And then you come back to this, and perhaps not a wakeful stage, but go to second, third, and this cycle repeats. And this these roughly, REM, the rapid eye movement sleep, and the non-REM, around 3 stages, they are, as I described. NREM stage 1 is transition between wakefulness and sleep. It lasts several minutes. Stage 2, light sleep before you enter deep sleep. Heart rate, all of these drop. Deep sleep is necessary for feeling refreshed in the morning. The sleep quality, you are looking at how much time you spend in this NREM stage 3, right? The deep sleep. And the REM stage, rapid eye movement sleep, when most dreaming occurs. Brain activity is high. It somewhat resembles like the wakefulness stage. And the next thing that we look at is the measurement of all of these different things. So the typically, when neurologists or other physicians require your sleep quality assessment, they send you to what is called sleep lab. Sleep labs are places where patients go and sleep under the supervision, medical supervision, where instruments are put on your body and brain, and the continuous recording happens during your 8-hour, typically 8-hour sleep lab workup. And the resulting data is called polysomnography, multiple modality measurements. So somnography, somno refers to sleep, and there is a recording of signals during multimodal signals during sleep. PSG is the gold standard for assessing sleep quality all over the world. And so PSG measures both sleep quality, sleep parameters, as well as the respiratory monitoring that happens. So there are several instruments. EEG is one of them. Electroencephalography, where electrodes are placed on top of the scalp, and a minimum of 3 channels representing the right frontal, central, occipital electrodes. I'll show you how these are. And a reference electrode, mastered electrode, is placed. And electrooculography, EOG, their eye movements are recorded. This is how you understand if the patient is exhibiting rapid eye movements when the eyes are closed. And two electrodes are placed, E1 and E2, for measuring ocular or eye movements. And electromyography, EMG, is a chin and other, chin EMG channels record activity from muscles in the chin, and leg movements are also recorded, leg muscle movement, right? So these are all electrical measurements, EEG, EOG, EMG. These have some bearing on the sleep. EEG is the most important one. EOG, as you understand now, the rapid eye movement can be inferred from EOG, but there is also an electrical signature during rapid eye movement. Both are present. Apart from that, there are oxygen monitoring, snoring sounds monitoring, plethysmography, which measures, these measurement that can look at, for example, the heart rate and all of this, abdominal movements, nasal prongs that look at airflow, temperature using thermistor thermocouples. So all these are, and pulse oximetry that looks at oxygen saturation. All these measurements are done, and typical, this is a patient from Nimhans, Bangalore. This is a typical sleep lab setup where all these instruments are placed on the participant. So in order to, this is the plethysmography on the, and abdominal movements, chest movements, leg movements, and the nasal, and the EEG is put on the scalp. All these measurements are taken while you're sleeping for 8 hours. Right, and this is the electrode placement on the scalp. This is the front. This is the nose of the patient. This is the back. So electrodes are placed. Mastoid electrode is here, the reference with respect to that. The central electrodes, frontal electrodes, occipital electrodes. This gives you a broad activity of the brain, right? So this placement is called 1020 system. We don't need to worry about that right now. But and then you place all these instruments and you record the brain, right? So this is a typical chart. This is a digitally recorded. This is a 30-second epoch. You can see that this is the activity of electrodes, 1, 2, 3, 4 of these. This activity between two electrodes, C3A2, C4A1, with respect to a reference, right? A1, A2 are the reference electrodes. O stands for occipital, C for central, and so on. So this is how the electrical activity in this 30-second epoch is. Like this 30-second epochs, you have a whole 8 hours, right? So you have two epochs in 1 minute, and then you have like this 120 in an hour and times 8. So it's a huge recording that is done. These are the EOG channels, EOG left and right EOG channels, eye movements. You can see the deviation in this, give you an idea of what's happening. Chin electrode, then ECG is also monitored, snore, sounds are monitored, temperature, and oxygen concentration, heart rate, all these are. The recorded file is called EDF, electronic data format file, is what comes out of the machine. And typical, in the next, I show a small video of how this, 1 second. Yeah, so you can see that this is the recording. I'll not play the whole thing. It's, but And so this is the playing. This is as time progresses, various channels. And you see these annotations are made by typically physiologists, right? Here annotations are made. The sleep physiology person looks at and makes these. There is also machine annotation, but these are quite bad. Typically, I understand. So they usually throw away what machine says it is, and then look at their rule book to see, based on different channels, they mark these as different epochs, right? So what you see here is N2, this is N3, and this is N, right? So these are different, right? They look at uh, this is the N3 deep. You can see that these are now slow wave sleep, and I'm looking for a REM sleep epoch. Right, so these are the spindles and K complexes. Uh, So this only this is the wakeful stage. Wakeful stage, you can see now how the nature of the signal is different, right? And you also have these leg movements, right? The video of the patient is also recorded. The video tells you if there is a leg movement, the leg electrodes give you an idea of that, right? So this is how R is, I think R is the REM. So you can see I think in these epochs where there is a huge movement because of the muscle movement that it affects. So this is a typical recording that is available. It's called PSG recording. This is the gold standard. And from this, typically looking at percentage of different stages, for example, amount of REM with respect to the total, what is the percentage of time the participant or the patient spent in REM sleep, N1 stage, N2 stage. These things have a bearing or importance for physician looking at the sleep quality. One of the problems that we took up was automatic staging of this sleep waveform. The 8-hour sleep divided into 30-second epochs. You have to, looking at the waveform, you have to decide is it what stage it is. So this kind of 4 or 5-way classification, automated sleep staging solution. That's we have done that. I'm not today talking about that. I'm talking about the feasibility of using EOG in order to assess sleep quality. That is my aim for today. But before we go into the solution, let me, so that this polysomnography data, PSG data, is divided into 30-second epochs or intervals. And the multiple epochs are considered to analyze, to observe what stage transition between different sleep stages and so on, right? So this is a 2-minute epoch where it is divided. This is right in this epoch. There is N2 the whole, and it goes into and you look for different combination of features, and typically we use only the EEG information, right? This is epoch 1, epoch 2, epoch 3. This 30-second cycles. Four threes, right? Is a 2-minute epoch. And there are certain guidelines from American Association of Sleep Medicine, AASM has a guideline in terms of how you assign a label to each of these stages. And so they have these scoring guidelines allows them to score something. If something is W wakeful, when more than 50% of the epoch contains either A or B or both. What is A? Alpha rhythm. It's a slow rhythm of a particular frequency band, and posterior dominant rhythm. It is dominant in the occipital region. Posterior is back. Occipital electrodes they generate the alpha rhythm. So this typically with the eyes closed, alpha rhythm in the posterior region shows that they are still in the wakeful stage. The other is eye blinks in this range. Rapid eye movements associated with normal or high chin muscle tone, and reading like eye movements. All these are either this are present, that one A or B or both are present, then it is considered a W stage, right? Like this, there's a rules decided by sleep physiologists and codified. These rules are what are used by physicians when they go through these 30-second epochs to decide is it W or N1, N2, N3, like this. And a sleep hypnogram is prepared where the different sleep stages, how much time they dwell in each of these stages is what is depicted in this fashion. This, you fall asleep, then go to stage 1, stage 2, stage 3, and this is 8 hour sleep, right? What you see immediately, 1, 2, 3, 4, there are 5 cycles, right, where you go down to the deep sleep, then come back to rapid eye movement sleep. Then you go down, go to the deep sleep, then come back. And you can see the successive REM stages, the rapid eye movement increases the duration. And typically, if you watch yourself, you see this early morning, right? If you slept at 10 o'clock and this is around 6 o'clock, right? Before you wake up, there's this long dream period, right? Early morning period. Just before the wakeful stage. And other thing that you see is as you go into your sleep, the depth becomes shallower, right? You don't go all the way to deep in as you go nearer to waking up. And this is the typical architecture of a sleep. And all of this is assessed currently. There is some automation. The machine labels based on some rules inside, but otherwise, this is done manually. And of course, problem with EEG based sleep quality assessment is poor signal quality, and electrodes need to be placed, skin irritation, all of this. And displacement, because this is an 8 hour long recording, it is possible that these positions get displaced during although you make sure they are in place by putting some band or something like that, but it's difficult. And sometimes the electrode may dislodge, come out. Then you have a missing channel. And it's a time consuming setup, precise. You need to make sure the impedance is appropriate, optimal, and you have to make sure the gel, if it is gel electrode, gel is not dried up and so on. And you need a skilled technician to do this. So all of this is being said to motivate that a wearable sort of solution for this would be a good idea. And so what we look at is current state of the wearable devices in this space, what kind of things people are using. The wearable solutions, and these wearable devices are used for not only sleep quality assessment, but to look at different sleep disorders, particularly sleep apnea. This is respiratory disturbance during sleep. So in some cases, respiration stops, obstructed because of nasal passage being narrower or whatever, and so the oxygen intake suddenly becomes low or non-existent, and that can cause hypoxia, anoxia, and that can be dangerous if it is persists for some time. So in some disorder conditions, sleep apnea needs to be measured. So this is a typical setup of how sleep apnea is measured. Example, the current variables such as PPG, photoplethysmography, and the accelerator movement monitoring, these are currently done, but mostly these are non-medical grade, for monitoring on your own for entertainment and things like that, or awareness in terms of what's happening to your body and what is the temperature and various things. Our aim, long-term aim, right now we are not there, but is to develop some sort of a mask that you can wear, which has sleep EOG, and we are thinking we also need to put one electrode for the brain data and two EOG electrodes, and use a combination of these three minimal set, that you should be able to get a very good account of your sleep quality. The current devices that are used for Fitbit watches and various things that are in market that give you some idea of sleep, they are based on accelerometers or accelerometer plus photoplethysmography that looks at the blood flow in a particular area, and heart rate and pulsations and all of that. So accelerometer plus PPG. So this graph here shows from 2013, in the last 10 or 11 years. This is from wearable devices for sleep staging from NPJ Digital Medicine journal, which gives you an idea what kind of solutions are present. Right. So this blue one is accelerometer based, right? So this has been there for quite some time. Many of our watches have accelerometer that give you an idea of the limb position, change in position, and movement, all that is integrated into wearable devices like watches. The other is NR is non-reported. It's not reported. We don't know what the solution is. But otherwise, the accelerometer along with photoplethysmography has been there for the last 6-7 years. Apple Watch and many of these have. Fitbit also has this. The currently the accelerometer for plus PPG there are about 9 such devices available. Accelerometer alone are fewer now, and of course there are some solutions which we don't know. They have proprietary sort of sensors. There are 62 type of devices that are evaluated in this review article. 45% use accelerometer alone, and another 45% use accelerometer plus photoplethysmography. So 90% of all these devices have this, and few of them, 3%, have temperature sensor also along with it, and multi sensory system 3%, but no PPG. This is a small percentage. About 4%, we don't know what these. Yeah, more wearable setups are investigated that include PPG data in sleep staging. So as we told, for this 4%, we don't know what the sensor input available for wearable sleep staging. All these are giving some account of your sleep, right? You wear this device and it gives you some account of your sleep. And I think what this review says is that most of them are unreliable or not validated clinically. Yeah. So problems with the currently available wearable devices, accuracy, reliability is poor. Different devices offer varying levels of accuracy and depends on the type of algorithm used and the quality of the sensor. And they tend to incorrectly classify light sleep as deep sleep or vice versa. And it impacts directly on the sleep quality assessment. If you're using this device to know how well you're sleeping, you may not be getting a reliable account of your. And the sensor limitation, limited type of sensors, which typically rely on motion sensor like accelerometer, heart rate monitor, which may not capture the full complexity. You've seen the sleep architecture, it's quite complex. And it's also possible that movement during sleep can displace sensors and therefore reduces the accuracy. So our idea is to explore the feasibility of EOG-based sleep stage classification. EOG is non-invasive, reduced discomfort, simpler setup, just have to wear the mask and go to sleep. In any case, a lot of you might be doing this when you are doing an overnight bus journey or a plane journey. This is quite common to use a sleep mask. And as we'll demonstrate, that REM sleep is quite a significant amount in your sleep, around 45%, right? This is what we saw in the previous slide, amount of. And so effective REM identification can give you a good account of sleep. And these eye muscle movement typically generates contamination or in the EEG. EEG is very low signal, microvolt signal, and then these muscle movements can cause a huge electrical disturbance, and that contamination typically makes EEG, purely EEG based assessment of sleep becomes difficult, where these EEG muscle movement related artifacts make you remove certain epochs because it's contaminated by high muscular movement and things like that. So and EOG based can be robust, and we are not suggesting you should use only EOG, but to see how much accuracy can we get if we just use EOG. But the ideal setup would be EOG plus one or two electrodes on the brain. The combination we think is the most feasible solution. Accessibility and application in healthcare, low cost and easier access, versatile usage. Patients can use this on their own at home. They don't need to go to a lab and artificial setting. Just wear this mask, and we are not there yet. I'm suggesting that this is a way to go forward. So what I'm reporting today is the answer to some of these. Can EOG signal be used as a viable alternative to EEG signals? A full EEG based setup for automated sleep, quantification of sleep stages. And the model effectively identify REM and other sleep stages, and how explainable is the model behavior. Right? These two we investigate. And the EEG electrode placement, according to the American Association of Sleep Medicine, is near the eyes, left and right eyes. And right. And you can also look at these EEG electrode and frontoparietal electrode. You can derive this if you have the the scalp electrodes also available. So what we did is, just as in the standard practice, sleep stage classification relies on present epoch. Suppose you want to look at this epoch and you want to classify this N1, N2, N3, REM. So it also depends on the adjoining epochs, the one after, one before. So we take that as one window, and using this window of three epochs, we will be labeling what is the central epoch. What class does this belong to, right? Like this epoch 4, you take 5, 6, 7, we sort of label what the middle epoch is consisting of. A window and stride, when the window is 3 and stride 2 here. Yeah, window is 3 epoch long, and you move it by a stride length of 2 epochs, you get this. So we use this sort of setup to assemble our training and test data. And we use one channel. In this case, I think we use the is done on several channels, but the one I think we report is the FPZ channel. For EOG, we only take the EOG recording, but if we use EEG, we take the EEG channels also. So we do feature extraction. Feature extraction is done not through traditional machine learning approach, but through the deep learning approach. And this block for feature extraction convolution, 1D convolution, is a 1D time series. The batch normalization, ReLU is the activation function. We use dropout, and there is the squeeze and excitation block that we introduce. This ResNet sort of architecture where there is skip connection also. And the squeeze excitation block has squeeze as a global pooling operation. And excitation block has a fully connected layer, ReLU, fully connected sigmoid. This sort of is the SE block that we embed. And after feature extraction, right? So this architecture, you have the SE ResNet that extracts the feature from inputs. And we have the transformer encoding, which has a positional encoding as well as a multi-head attention. And we use this, and then a linear layer followed by softmax for classification, the final. This is the overall architecture. And the data sets we used are publicly available data sets. Sleep EDF is a 20 and 78, 20 participants, 78 participants. This data set available on PhysioNet, MIT PhysioNet database. SHHS is also another huge repository of sleep recordings. We take 329 recordings here, 70 subjects contributing to 153 recordings, 20 subjects contributing to 39, roughly 2 recordings per head. We take all these as our data set. We conducted 5-fold, 10-fold, 20-fold cross-validation for respective data sets for training and testing the model. Right? So, these are some of the performance results. We compare our method against 2 of the existing methods. EOGNet is from This paper from Fan et al., EOG-NET, a novel deep learning model for sleep stage on single channel EOG signal. This is published in Frontiers in Neuroscience 21. And the other one is Supratak Dong and Wu Guo, published in IEEE Transaction Neural Systems Rehabilitation Engineering. It's called Deep Sleep Net. This is published in 2017. This is a deep learning network that takes EEG data. So this is based on EEG. This is based on EOG alone, but they give performance both on EEG data and EOG data, right? So EEG data obviously gives you better accuracy, 82%, and this F1 score, 76.9. Kappa score is what is always reported in these EEG analysis. Kappa score is called Cohen's kappa coefficient, is a statistical measure that evaluates how well the predictions from the model agree with human raters. In this case, sleep physiologist has given a label, the consensus label from human raters, and how is your prediction? What is the coherence or consistency between? So it gives an account of that. The higher the kappa score, the better. Just like other scores, accuracy and there is a drop in performance if you use EOG alone, right? EOG is also 1D time series signal. You can in practice we can also train a network with these 1D time series, and you get only 73.5, and all these things drop. And similarly, EOG net alone 76.3 is better than this, but still worse than if you were to use EEG. Right? EEG, remember, is it's kind of gold standard. It has much more information than simply eye movement. Remember, the whole sleep is not just only about eye movement. Sleep also has slow wave, sleep, the alpha rhythm, theta rhythm, delta, all these are not completely captured by EOG. It's possible that EOG captures some of that, and that's what we suspect. And our architecture gives you a very good accuracy, better than most of the other solutions, 79.3 with MF, the F1 score of 74.7 with a good kappa score. Of course, if you use EEG, you get better, right? These are EEG based, but this already shows you on sleep EED 20, you get very good, around 79% accuracy in the sleep stages. So our first question was, is it feasible to use EOG alone to assess different stages? And so it looks like it is feasible with a good method, appropriate method. This is the overall metrics. And so sleep EDF 20 classification performance or model on the all the other data set with single channel raw EOG input. Of course, class wise, the accuracy is different. N1 is very poorly, all the models. In fact, we don't show it for other models, but N1 is one of the harder ones to classify across data sets, across algorithms. Is the typical challenge. The rest of them have very good, they yield good accuracy. And right, that this is the 79.3 that we talked about earlier. And this is the confusion matrix, W, N1, N2, N3, RAM. What you see here is N1 again has 43% that is done. Rest of the N1 is always confused with either N2 or W. the wakeful state. Otherwise, the remaining N3 also has poor 68% is confusion with N2. N1 and N3 are N1 is the transition between wakeful to N2, and N3 is transition between non-REM and REM. So and it turns out, and as you can expect, because this is EOG based, remember that the signal we are using is the time series signal that comes from the eye movements, right? And I would say it's quite remarkable that we can actually recognize the other sleep stages. The REM is now if we were to talk about REM versus non-REM, we would have basically done very well, right? The rest of them are non-REM, and we are able to recognize wakefulness and REM at a very high rate of accuracy. And on sleep EDF as well as SHHs, the qualitative picture is similar, right? So the N1 and N3 are inferior compared to the other stages of sleep. So this is the normalized confusion matrices on fold zero on all these data sets. And going forward, what we did is explainability, that is looking at what is the so using this multi-head attention in this transformer, look at the attention weights to understand when it is saying it is REM sleep, what channel, I mean, what is it focusing on, what is the weight. And you can see that the GradCam is a way of visualizing class activation map. Then you can see that the attention is on REM epochs when it is doing range of red hues to emphasize particular segments of the input signal that have major influence on the model's final categorization decision. This is a 30-second epoch, and it is paying attention to these that have a bearing on this epoch being a REM epoch. And blue boxes that serve to identify the presence of rapid eye movement artifacts as identified. So this is the waveform, these segments we gave to the sleep expert. In our case, NIMHANS, blind, we supplied some epochs that the model has evaluated and given to the expert. Expert also concurs on, in many of these cases where the model thinks it's REM, expert also agrees it's REM. Of course, it's not always perfect, obviously. That's why you have only 80% accuracy, right? This 20% of the cases where it does misdiagnose or mislabel, right? That, but it's a good concurrence on some of these REM versus non-REM. And this is the the stochastic neighborhood embedding SNE plot, T-distributed SNE plot. This a technique that allows us to visualize in a low dimensional, in lower dimensions, visualize what is happening in this EEG, EOG signal space, right? So this is the different epochs, different classes are labeled W here. The blue are all wakeful. N1 is orange, N2, you see that fairly good separation. And there is also confusion. N3 is confused with N2, and we see implication of that in a confusion matrix as well. And N1, for example, which is at the border of wakeful and the REM, I mean non-REM, other non-REM stages, that there is a lot of orange overlapping with both N2, which is green, and W, which is blue. Right, again, this manifestation of this we see in the in this confusion matrix, at N1 confused with this W and N2, and N3 is confused with N2, right? We see that in this distribution plot as well. These are W and N1. This is individual. REM sleep is quite distinct, right? In this, the purple ones is the REM. So complex features that are extracted from the convolution layer of the SCNet. Remember that feature extraction is the squeeze excitation ResNet that seems to, so these, so the this output here is from the SC ResNet plot to look at what kind of features is SC ResNet supplying to the rest of the transformer architecture for downstream classification tasks. Right, so the feature separation seems to be fairly good from this proposed SC ResNet block, and clustering pattern that corresponds closely with the existence of 5 distinct classes. Now, of course, as I told you, overlap that you see in the confusion matrix. So also in the feature space, we see these overlaps. This is what we are proposing. We have not built a proof of concept, but this is what we would like to do. That you can actually place these EOG electrodes on a mask, and we can actually collect new data, and then correlate with the PSG gold standard data. So this feasibility study that we are reporting shows the viability of using EOG alone, and right. So in the future, we'd like to actually see this mask made and validation done. Limitations of the current study: we haven't tested this on people with disorders. Right, so this whole experimental setup that you see is on sleep EDF 20, sleep EDF 78, SHHs. These are all healthy control participants. Normal healthy subjects contributed to this EEG repository. The sleep EDF has both EEG channels as well as EOG channels and various other channels also. There's ECG and chin electrodes, abdominal movement, all this data is available. So we use the EOG channels to look at the feasibility. This is tested only on healthy participants. We have to look at disorder and further improvements in N1 stage classification as well as N3, right? Which are two that are difficult. And one of the reasons we think, then one can ask the question, why just looking at eye movements you are able to distinguish other sleep stages which have different electrical signature, which is really not captured perhaps in eye movement. What we believe is there is some correlation. There must be some correlation between the EOG 1D ocular muscle movement recording that we are seeing, electrooculography, with the EEG, and it might be possible to extract this EEG and use for this multi-way classification. And of course, we need a lightweight if this needs to be used in practice. So this is the link to the paper. It's published in ICASP last year, 2014. It was held in Korea, Seoul, Korea. So you can, it's available. So then in the next 5 minutes or so, I want to talk about the data set that we curated with the collaboration from NIMHANS. This is called the iSleepS data set. It has polysomnography data set for sleep analysis in ischemic stroke patients. Stroke patients data and this PhD data, which is annotated by NIMHANS physiologists. And this data set we wanted to put out. There is no Indian EEG data. We thought it will be helpful going forward for many of you researchers can look at this data and develop newer and further solutions. And so this 100 participant detailed PhD recordings we have collected. Clinical annotations includes patient age, gender, and diagnosis in terms of what kind of apnea, hypopnea present, and other things. And apnea, hypopnea events are also marked. This detailed annotated data we are planning to publish and keep it for public access eventually. It will take a couple of months more, yeah, just consolidating all of this. Potential uses for medical research. There are particularly no data sets available between stroke and sleep. What is the linkage? And there is clinical intuition or insight that disturbed sleep can also have consequences for stroke and sleep apnea. And AI model development using this data set and public awareness. And the data set is composed of close to 800 hours sleep recording data, right? 8 hours times 100 patients, 800 hours is 90% of the files containing 7 to 10 hours of data, and some have more than 8 hours, right? And this is from 20 to 28 channels, multi electrode recording. It also has EEG, EOG, EMG, and various other sensors. All this data is available as part of this iSleepS. So what is shown here is different participants, and so this is the annotation by the sleep physiologist. You understand the value of this, that the painstaking manual annotation of this has been already done. Wake stage. So what is shown for each participant, their 8 hour sleep data, how frequently are they in wakeful state, N1, N2, N3, like that. And so this gives you an idea of what the quality sleep parameters across the participant, the stroke patients who contributed to this data set. Patient distribution, severe apnea, moderate apnea, mild apnea, normal 15%, remaining are all. And this high average number of apneic episodes per sleeping hour, and how many patients have this 10 episodes, 70 episodes, 80 episodes, right? And fewer, close to no episodes, how many patients are there? So this is the distribution of AHI values. And so we built some baseline models on this ResNet 18 and the squeeze excitation ResNet that I talked about, and classification either by LSTM or transformer. This is not just EOG. We did, this is the accuracy CNN based. This is of different, you can see that the CNN based by far does better for most of these, right? The or LSTM based is actually better for this. So this is the hypnogram manually recorded by sleep expert. This is the hypnogram constructed from CNN based model, for example. And so this is typically used for kappa score calculation, right? How well the model agrees with the annotations and so on. This is example of a sleep data set that we have worked on with the help of funding from iHub Data, the Technology Innovation Hub. And the future scope, to sort of wrap up the last slide, is that a health monitoring system based on wearables is, I think, is quite uh, important and cost effective for a situation like India, where the number of physicians, especially, right, qualified experts who can look at such data and give an idea of the quality. These are very few, and people have to travel long distances to get their sleep quality assessment. Sleep is one aspect, but there are many other. What we think is that you can use a suite of wearable sensors capturing multiple things, snoring events, EOG, vital signs. Use that. Use a smart mobile device to capture through Wi-Fi, and then applications built on top of this to digest this data, and then present the possible outcomes, right, the uh, that provides first-hand information to make an informed choice, and in some cases alerts are generated to take immediate action if there is something which goes above some threshold. And that this data will also be helpful for physicians when, typically a physician comes into the picture. It is a snapshot they will be looking at. But if you have this recorded data, they get an idea what is happening over length of time, and that makes it easy for them to take a more informed decision. I think for a large country like ours, cost effective and flexible solutions that do not require a lot of patient intervention, I think will make a huge difference. I think, I mean, the healthcare delivery, if it has to be sustainable and responsive, electronic healthcare would require more and more solutions like this. Today, I just talked about sleep quality. There's a whole bunch of things that we should, as engineers, we should be able to do. I think we have a huge role to play in the next 10, 15 years, where healthcare is one of the things that has become inaccessible, unaffordable, and early screening, prevention will save a lot of money and lives. And I think technologists like us have a huge role to play in this. And I congratulate the SR University team for choosing this topic, AI in healthcare and healthcare technology. Very, very important. Some of the publications that related to this ICASP that I talked about. This We are writing currently, planning to submit, and we submitted another solution, this deep learning based sleep stage classification, so that you can access. This is the team from brain computation cognition lab. So he is Swadeep, whose work that I presented today is our photograph of all the students from cognitive science lab. Mm. And Kamlakar is a postdoc fellow, the research scientist who is also helped in the other parts of this sleep stage classification. Okay, and thank you. And any questions, comments?
Thank you, sir, for giving this wonderful lecture and letting us understand the complexity of the not just the data set, but also the methodologies that go into it. Before others can type in their question, I'll like to get some quick questions in.
Yeah.
So one of the things that is consistently happening is that the no matter what models we are using, at least 20% um, errors are there in underlying, like identifying sleep stages. One of the reason is, of course, you have said that it's a complex hierarchy of sleep stages. Um, but what can be other possible reasons for like not crossing that 80% barrier? I mean, is it a certain kind of are we fundamentally missing something, some signal that we are supposed to sense, or is it that we don't have enough redundancy?
One of the things, yeah, that's a very good question. I mean, why are we seeing, why is there a gap between, so one is artifacts, noise in the signal is one, other is uh, also some inter-rater variability. I think the consensus you will see also in the rater, because this ground truth is actually the manual rating of by experts. And there is some, I don't have that data here, but that there is also some inter-expert disagreement as to if, especially in those stages that models are also seeing it difficult. N1, for example, is confused with wakeful or N2, and similarly N3 is confused with N2. So what human experts do is look at, in those cases where they are doubtful, they look at other channels. They look at abdominal movement, they look at chin electrode, they look at oxygen concentration, right? They look at multiple other, they are at ease too, right? We are not training these models to look at multiple. Uh, so that's how they come to a consensus. So there is additional information that we are not able to provide currently. I mean, people tried using ECG, and but with not much success, right?
Mhm.
So this inherent complexity of the signal is one thing, but noise, artifacts, and also the AASM manual, American Association of Sleep Medicine. This is a consensus among sleep experts
Right,
as to what constitutes N1, N2, N3,
right, right.
right? And there is a rule book, and say
Right,
if you fail to see something, you look at that channel, that and other
right,
channel,
right,
and if nothing, you look at the previous two epochs, right? And
right,
we are able to give the temporal context by this windowing
right,
approach, but
right,
not more than that, right?
right,
I think all of this contribute to this gap.
right.
Uh,
Yeah.
Yeah,
I think it's
one
a,
other question I see on the
hmm,
chat is eye sleep as data set composition. How is measured the
is the
levels?
levels. Yeah.
Uh,
Like, and
so this,
another
yeah.
related question also, another related
Oh.
question is that how many factors we have to consider for eye sleeps, as it is varying from person to person. I think both the questions are related. If you can answer both of them.
Yeah, so so this name Swadeep came up with. iSleep is Indian sleep data set. So it's a data set name that we have given. Our idea was when we were doing all this over the last 2 3 years, we have been working on this sleep stage. Uh, we have not found any Indian data, first of all. We thought it's very important. So that with the help of the NIMHANS sleep lab, we worked with them to curate this data. And so what do people like us, what do we need? We need annotation, right? We need to know what the sleep expert thinks, what epoch, or what this epoch is. This a wakeful epoch, this is N1, N2, all those annotations we got from them. And We wanted to make this useful, so we asked them to also annotate if looking at the airway channel, is there an apnea, sleep obstruction present? And what is the severity of this obstruction? So, sleep apnea is measured or is visualized by these physiologists looking at the airway obstruction as well as information in the electrical channels, EEG channels. So, using that, they came up with these scores. Those are also available. And when did stroke happen to them? Was it 3 months ago, 6 months ago? How long before when they were done sleep? All these factors have been recorded, and they are all available along with the sensor data that includes ECG, EEG, the abdominal chest muscle movement, EOG, eye movement, chin movement, and the oxygen concentration, the airflow, rate of airflow, all these, whatever has been recorded as part of this instrumentation that's hooked up to the patient during the sleep lab workup. All the data is part of this repository, along with expert annotations on what is happening in this. And I think some clinical information as to what medication they are on, they are also present in these, and their age and gender and so on. So we think this is going to be a very valuable data set, not just for India, for all the researchers that who work on this in this area. And most of, I think, as I emphasized before, most of the other data sets are on healthy participants. On disordered, on patients with some disorder, stroke particularly, there is no data set. Uh, Stroke and sleep, or stroke is obstruction of blood flow. This is ischemic stroke, not hemorrhagic stroke.
Right,
The
right.
stroke, two broad classes. Ischemic stroke is where there is obstruction in the brain blood vessels that causes stoppage of blood to certain region and death of neural cells that may cause paralysis or action or sensation, loss of sensation, or movement, or in some cases, depending on the location of this particular obstruction, it could be speech that is impaired, or upper limb movements, lower limb movements, or a whole side paralysis. All this can happen. At that, this stroke and its relation to sleep has been important for neurologists. So one of the intuitions the neurologists we are working with is that sleep disturbances are early indication precursors uh, to onset of a stroke, a recurrent stroke in person who already had one stroke, right? So that it
Right.
becomes important to monitor. And
Right.
so that's the context in which I talked about. Is there a
Right.
effective
Yeah.
home-based monitoring possible?
Right.
Right. That's
Right.
the
Right. Thank you, sir. I'll now hand over the session to Dr. Ravichandar, our coordinator. Uh, Hello.
You, Dr. Bapi garu, for a
Yeah.
wonderful session. And thank you to Rakesh Gupta for coordinating this session. Now, next session will be by Rajesh Kandala from VITAP. So, participants, please be patient.
Okay.
Next session
Yes.
will be by
Right.
uh,
Bye, sir.
Rajesh
thank
Kandala.
you. Bye.
So, Rajesh Kandala sir is there?
I think he's here in the session. I've made him co-host also.
Okay.
Dr.
Yes,
Rajesh.
sir. Rajesh sir, I think you have to unmute.
He has been made co-host, so
Hmm.
he should be able to unmute himself. Oh no, he has. He's not yet now. Wait, I'll just check.
He texted
Can you call
me.
him?
Yes, yes, he
He
told me that
was here
already
just
joined.
now.
Already joined. He texted me.
He had joined. I had checked, but now he's not. Can you call him again?
Even though co-host, sometimes it is.
I made him co-host, but he's not in the list now. Let me see. A second. He's here. I'll just make him co-host. Yes.
Sir, am I
Hello, Dr.
audible?
Rajesh.
Yes, sir.
Yes, you're audible.
Yeah, there is a mic problem before.
Okay.
And no issues. So I'm handing over the session now to Dr. Ravichandar.
Yes, sir. Okay. Thank you, sir. Thank you, Professor Rajesh Kandala, for joining this session. Today, I'm going to introduce our Professor Kandala NVPS Rajesh Garu. Professor Rajesh did his BTech in ECE from JNTU Kakinada. He did his MTech in signal processing from JNTU Kakinada in 2013. He did his PhD degree from VIT Vellore in 2018. He is an associate professor with School of Electronics Engineering, VITAP, Vijayawada. His research interests include biomedical signal processing, image processing, and machine and deep learning. He is an active reviewer for various peer-reviewed journals, publishers like IEEE, Elsewhere, Springer, Frontiers, etc. He had very good number of publications in reputed journals as well as international conferences. He is book editor also. He served as a guest editor for Frontiers in Human Neurosciences and some other journals. Thank you, sir, for joining this session.
Thank you, sir. Thanks for your introduction. Uh, shall I proceed, sir?
Yes, sir.
Thank a very good evening to all the participants who joined this session. And let me present my screen. Sir, are you able to see my screen, my PPT?
Is visible, sir.
Thank you. So, once again, I welcome all the participants for this FDP on AI innovations in healthcare and medical technologies. Is organized by the SR University. So, in this session, now what I'm going to focus on this AI-driven ECG signal processing for cardiovascular health. So, my most focus will be on signal processing, basically. So, let's begin with some motivation. Why do we study this particular concept? Okay. So, as you know, this human body is made up of a lot of organs, and if any disturbance occurs to the one of these organs, then it will lead to some pathological situations. When it comes to cardiovascular diseases, it is one of the majority of the uh, diseases that is leads to mortality, especially the low and middle income countries like our India, South Africa, Egypt, and so on. And again, most of these CVD deaths are because of sudden cardiac arrest, and arrhythmia is one of the responsible things for the sudden cardiac arrest. Therefore, it is a, a alarming situation that we need to identify these arrhythmias beforehand. So, early detection of these arrhythmias or arrhythmia classification is one of the crucial things to diminish this mortality rates of cardiovascular disease. Now, what is an arrhythmia? It is referred to any cardiac rhythm other than normal sinuses. So I just tell you how heart also works. So this actually this session how I am going to take is uh, first of all I just give some basics of the problem, that is arrhythmia classification. First we should understand how heart functions and how the pathological situation comes and what we know them, and like arrhythmia, what is the types of arrhythmia and all those things we'll see first, and then I'll just introduce you with the coding part. Like I try to do some coding along with the problem. Okay, this is how this particular session will go on. Now coming to the arrhythmias, arrhythmias are of two types, and these are formed inside your heart due to this improper formation or the improper formation of the electrical impulses or the obstruction of this impulse in any way anywhere in the conduction pathway, and they leads to different types of arrhythmias like premature ventricular contraction, premature contraction, or some bundle branch blocks. So what are the tools that are there for to identify this arrhythmia? Basically, this can be broadly categorized into two ways. One is invasive, other one is non-invasive. Invasive means something when you input inside your body to test, okay, either a camera or a needle or whatever. If you place inside your body, then we say this is an invasive method. Or else otherwise, if you place something on the surface of the body, the electrodes or something, if you place on the surface of the body and you try to collect the information from it, then we say it is a non-invasive method. ECG or electrocardiogram is one such method, and it is one of the primary diagnostic tools that we use to identify the electrical activity of the heart. And this using this, people used to first find the arrhythmia. If there is any major pathology situation which we observe, then the people may suggest you to go for some invasive method like angiogram. But however, the primary diagnostic tool is ECG, and the reason behind this, it is cheap and it is a non-invasive method. And now we should understand how how an ECG looks like and what is ECG. As I mentioned, it is one of the primary diagnostic tools, and it represents the conduction of the muscular activity of the heart. So it's generally we called as depolarization and repolarization of the cardiac nerve. That is what we closely say. Generally, we in our language we say like lub-dub. This lub-dub action will be captured not only for sound with sound, but also this contraction, relaxation of the cardiac muscles can be captured using this ECG signal. As I mentioned, why people relying on ECG is because of its simplicity and risk-free environment. And here you can see a sample ECG waveform, and where you can find some numbers on top of the ECG signals, like you can see 2, 3, 4, AVL, AVF, V1, V2, V3, V4, V6. These are all represents the electrode information where we place on the surface of the body. Okay, so that implies ECG is not a single signal. It's basically we place it many places, just like this. You can observe the electrodes will be placed on your chest, okay, and your limbs. And using these references, we will see the different dimensionality of the signals. Means in different ways, we will understand the action of blood pumping inside the heart. So through valve, these valves will be there. It will be there, and it will pass the blood throughout the body. So therefore, all at major locations, we place these electrodes, and we will get the information of conduction of the heart. So there are plenty types of ECGs are available. Generally, if you go to the doctor, the first test maybe they suggest is this resting lead ECG. That is, you just lie on a bed and they will place electrodes in a different places. This is something called conventional acquisition of your ECG signal. Okay, that is something called 12 lead ECG. Whereas there are some cases, for example, you feel now there is a pain in your chest, and maybe you go to the doctor tomorrow, and the same vital signs may not be available. For this reason, we cannot rule out what happens to you. Okay, in such cases, what doctor prefers is this exercise stress. So what they insist you to do is you take some treadmill exercise. In this process, they will analyze your heart functionality, because generally we observe these abnormal changes when we are in some kind of action. Okay, so stress. So that will be synthesized in the laboratory using these kind of tests. Okay, even sometimes this vital signs related to pathology may not be observed. In such cases, what doctors will suggest is a Holter monitor. So this will be a device that you will carry for your daily purposes. So daily activities will be going on. Maybe you will carry it for 24 hours or 48 hours, and the close examination of these lengthy ECGs will be taken place to understand the situation about your heart's condition, right? So this is called Holter monitor or ambulatory ECG monitoring. We say it ambulatory ECG monitoring. Why? Because wherever you go, you carry this device, and whole your activities will be recorded in this device, and this will be monitored later through this kind of techniques. So as I mentioned, what are the challenges that relies in this ECG signal analysis? As I mentioned, the first one is whenever you carry this exercise ECG test or Holter monitor test, the problem arises is it is a lengthy kind of thing. This is long-term monitoring has to be taken care. Okay, when the pathology occurs is very important to identify this. We need to examine whole 24 hours duration of the ECG signal, and is obviously a tedious job for any human being. Okay, and there are plenty of chances to um, oversee the problem. Okay, so to avoid that, we need some specialized things called computer aided diagnosis. Okay, we just rely on this computer aided diagnosis. As we know, computers can work for lengthy hours. Okay, so hence the this makes towards this computer aided diagnosis. That means whatever we are now working on, the machine learning algorithms, deep learning algorithms, all came into existence. Okay, as I told you, it plays a crucial role in clinical diagnosis. Or else, however, even though we cannot completely rely on complete this CAD, it just helps your clinicians as a second opinion, and always the clinician's expertise must be taken care into the decision. So whenever we want to take some decision, it just takes the help of the computer diagnosis to recheck what happened. So in such a way, we can implement or use these computer-aided diagnosis methods. So this is what we use the major building block in the analysis of ECG. That's what we call computer-aided diagnosis. Here, the diagnosis is about arrhythmia classification. So here we want to see that pathology. Arrhythmia is basically pathology, which is not the normal sinus rhythm. Normal ECG follows one pattern. Okay, if I am healthy, it follows a pattern. If I am unhealthy, it follows a different pattern. So different patterns may reflect different pathological situations, and it is very complex to see just with a human eyes, and hence we need all these kind of specialized signal processing and machine learning techniques. Okay, these are handy in analyzing those things. The common things which are there, the common building blocks to implement such kind of computer diagnosis systems are as follows. Basically, any data which comes to you, this ECG data, it may have some error noise, okay, that we need to be removed. This noise has to be removed so that that filtering action to be taken place. Okay, there are cases, we will study them later, and later the ECG signal comes to you. Okay, how to identify something is there means we need to identify the best, we need to figure out the best characteristics which are there inside the ECG signal to make a differentiate between healthy and non-healthy. So hence we have to identify some important epochs. These are called events. So detection of events or epochs is very important task. Okay. Later, from that, we will fine tune it further using the feature extraction methodology, where we will extract some important features, the characteristics or the attributes that are related to those epochs or segments. And finally, we give these set of features as as an input to our machine learning algorithms to feed, and it will return you an output based on your particular problem. So say for example, it's a binary classification which I am showing here, normal, abnormal, and it could be multi-class. I can add as many as I can. According to my data, it will process and gives us the data. This is what AI driven, where we use this machine learning or deep learning algorithms. So what I am going to do from now, I just introduce you with basics of filtering and feature extraction and detection of events, and followed by that, we will use some of the features to classify the data. Okay, so this is how this session may goes now. And even before, let us understand more on this particular ECG or heart. Maybe not everybody is very related to this particular concept. Okay, though some of their research areas is biomedical, it is not necessarily they are working on this particular ECG or heart. Maybe some of them are working on this
Rajesh sir?
I'm sorry, sir. Am I audible now, sir?
Yes, sir.
Okay, okay. So I hope just now I was muted this. Am I right? Or from beginning I was muted. Okay. So I hope you're listening to this. Okay. So now, actually, as I mentioned, not everybody is related to this heart functioning and how these arrhythmias can be understood or ECG signal can be understood. So I just let me give you a brief introduction how to understand an ECG signal, basic ECG signal, what actually it implies. That let us look into that. Okay. So here you see our primary focus on this particular heart are a few things which will start from this sinoatrial node. So or also we also call it as a sinus node, which actually triggers the action of your muscular activity, and this is what responsible for your blood pumping action even to send it out to whole body or to collect some impure blood to make it pure. So this sinus atrial node or sinus node is very much responsible for this. So let us see this more in this particular second slide. You see what will happen. Just observe what is happening here. So if you observe in the above figure, some red color thing is passing through your heart, and in the below you can see some waveform is reflecting to it. There, what I say this is called some electrical impulse activation, and that is what I said in early. Arrhythmia is something irregular electrical activity. What is this electrical activity and how it is responsible? First of all, we must know the basic functioning of the heart. If you look at the heart has majorly two chambers on the top and two chambers in the below. The two chambers on the top, we call them as atrium. So right atrium and left atrium. Okay, this is a right atrium and this is a left atrium you have, and the below you have ventricles. Right ventricle and left ventricle, you have two ventricles. Okay, here what happens through the superior vena cava or the inferior vena cava, the blood, impure blood will be collected through these atriums. So atrium will collect the blood, and this is what impure blood, that is deoxygenated blood, and through these valves. Okay, so what it will go is this impure blood will go to your pulmonary system where it will be oxygenated, and again through pulmonary vein this will be entered into your left atrium, and this is something, the collection of the pure and impure blood via atriums. And basically what happens, okay, after collecting this impure blood, it first goes to your ventricle. Okay, this is to right ventricle to tricuspid valve, and then it will goes to your pulmonary, and it again comes to pulmonary vein to your atrium, and again it goes to your ventricle. Every time the collection is from to atrium, and then it will go to ventricle, and the ventricle takes some contraction, and whenever it contracts, you see out of all these four chambers, the left ventricle is the biggest chamber, and once it got contracted, the whole blood will be pumped throughout your body, they oxygenated. So here in these chambers, left side, you always see the oxygenated blood, and here is always a impure blood, and this action will be continuous, or else otherwise we don't find observe our heartbeat. So this is what the whole action of what I said for one time is called one beat. Okay, one nub, one dub takes place as a one beat. This is what you can see here. This action is one beat. Here you can see an ECG signal of one beat. Okay, from this how you can understand in an electrical way. First, this will trigger, then the action starts. Your aorta, sorry, your atrium will be contracted. When it contracts, okay, when it contracts, the blood will go to your ventricle, and from at the same time, this is a parallel process will happen, and later ventricles will be contracted, and blood will go either pulmonaries or through towards the body. And this is what this contraction, see here contraction blood comes, and again this contraction. So this contraction or depolarization creates this ECG signal. So this is what an ECG signal of one beat, and here the P represents atrial contraction. Here this contraction in atrium portion, that is what a P represents. As it is a very less contraction, you have only see a small amplitude change here, almost a very less amplitude, 0.1 to 0.3 millivolts. You can see the P wave. And as I said, the ventricle is the major chamber and this is the biggest chamber, and it is responsible for pumping the blood throughout the body. This is having a largest contraction among the other chambers, and hence it will resulting in a QRS peak, maximum amplitude change. You can observe here. This is called the depolarization or contraction action, and again followed by that, you have a little uh, resting phase of the ventricles you can observe, and that will give you a small amplitude, again is called T, and then this process continues. So altogether you will see observe a lot of ECG beats. Okay, as I mentioned, This is a QRS, ventricular depolarization. This is a atrial depolarization or contraction, and this is the ventricular resting position called ventricular repolarization. This is basically, and this ECG signal, this you must know what is P, what is QRS, and what is P, and they are called the important epochs which I mentioned earlier. Okay, the basic segments. So this is one ECG beat, one segment. In this segment, the important epochs are P, QRS, and T, and which will influence us. Say, for example, using this, the pathologist or the clinicians will understand, is there any problem with your heart functioning? Because if you observe a general or normal ECG signal, it should reflect this kind of waveform. If anything deviates from this, you can maybe guess that there is a problem in that. You can interpret that. Okay, I will also show you how a normal ECG looks like and other pathological ECGs look like. See, you see, this is the normal ECG signal, and it has the characteristics or like normally, we all know that our heart rate, that is beats per minute, is generally varies between 60 to 100. And this is the QRS complex, as I mentioned previously, is just preceded with P. Just after P, you will observe a QRS. After that, you will have a normal T, and just like this. And it depends even where you are observing, in which lead we are observing. Accordingly, you will find whether it is a normal or abnormal ECG. If you consider the abnormal ECG case, for example, PVC means some extra beats, ectopic beats. We also call them as ectopic beats or preventricular ectopic beats. That means this action is not going well. Okay, there is a unsync between atriums and ventricle. Here also a conduction may start. So before it starts conduction here, if the conduction starts here, there is a chance. Then you will observe an extra beat, something which is not in the sync. Your pumping action not in the sync way. That means what happens here? There is no full blood, but still it starts pumping, squeezing. That will arises this kind of extra beats here. You can observe here in general. So there is some extra beats you will observe here. So this is called the PVC, and it has some kind of characteristics, like you see the broad QRS complex. Because why broad means this is not in sync, and QRS starts pumping early, and you can find some broad QRS. And as I mentioned, premature early, it would be expected in the next time impulse. And your ST segment and T also changes. Some abnormal changes you can find. The same kind of things you can even observe in other situations also. And where the problem arises accordingly. So, for example, if the problem arises at another place, then you can find another type of arrhythmia. Okay. So basically, what this action, this is very important action, is known as pacemaker action. Generally, people with heart problems will be implanted some pacemakers inside their heart. What is the pacemaker will do? Okay, it does the same process. The natural pacemaker of heart is this sinus atrial node. If this not works properly, anything may take this duty. Okay, so if they are all not doing it well properly, then an additional triggering activity must be taken, and that is what your pacemaker is. Okay. So this is how you can observe different types of arrhythmias. Okay, so why should we study about all these arrhythmias? And no, they will generate some adverse effects. So, for example, the frequent episodes of these kind of arrhythmias can lead to a serious problems like atrial fibrillation, ventricular tachycardia, heart failure, or cardiomyopathy, and like many problems may arise. So, early identification or detection of these arrhythmias is very much required to mitigate the issues related with this heart. Okay, this is what the motivation and the basics that are related to the heart analysis. I hope you people are following this. As I mentioned, you see, these are some of the heartbeats. They are all same type, and they are different from this here to this, here to this, here to this. And you see, I said they are all same, but still there are a lot of differences among them. Here, all are ventricular ectopic, but they are different. Supraventricular, different. Fusion, different. Unknown bits. See, they're all different arrhythmic beats. Here, the problem you can understand from this picture that inter and intra variations are very tough to analyze. Say, I cannot say this is a normal just by knowing only one quality of it. There are several qualities associated with this. Say, for example, here I mentioned if it characterizes like this, it is a normal. However, similarly, at the same time, they said like P waves are upright in leads 1 and 2 and inverted in AVR. Generally, they must be in this way, the P waves. But in augmented VR region, you can see the P wave is inverted. The below, you can find the P wave. And with that, you cannot say it is an abnormal beat. Still, it is a normal beat. And it is a condition where you normally observe in AVR. So, you need to know a lot of information about this to analyze this. So that expertise is so important, and this is where the problem arises. Nowadays, this expertise is lagging, and hence the people are really relying on this kind of training methodologies, that is AI models. I hope you got this motivation behind using this AI models. Now, what are the tools that are available to understand this pattern classification or arithmetic classification? Generally, we have a lot of tools. Like what I use mostly are MATLAB, Veka, and Python. These are the tools I often use. Okay, maybe I'll give some examples to MATLAB, the initial signal processing operations. Later, I will show the classification problem using either MATLAB or Python. Okay, based on the time terms. Give me a moment. So as I mentioned, let us first focus on this pre-processing stage. Just now, I'll introduce you with the ECG signals, how they looks like, and in which formats they are available. And using MATLAB, you can use all these formats like CSV, text files, XLS, XLSX, .NET, .NET. All these formats are good at processing using your MATLAB. Here I will show you an example. An ECG signal looks like. Here the data, as you know, I am loading a data which is in the format of dat, and the data is a digitized one and has a sampling rate of 200 H. And later for plotting purpose, I am converting this into time duration just by dividing, normalizing it with FS. So let's see the answer. So this is how your ECG signal something looks like of 20 seconds. Okay. And variations you can observe in this signal. So you have the beats. Generally, the beats will be counted using the R peak. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Just above 20 you can observe. So per second, maybe a 60 or 70 heartbeats you can observe. Generally, we can interpolate from this. We can interpolate how many heartbeats per a minute. That's what your watch, the gadgets will do. Okay, it takes some data of some duration and then interpolates, and it will let you know the information per a minute or a hour. Per hour, how many heartbeats, or per minute, how many heartbeats. The heartbeats per minute, that is coming through this analysis. So they just count for a small duration and will be interpolated for the longer durations. So this is how you can plot your ECG signal. And for example, just only a few moments you want to see, observe at least one heartbeat that you want to see. You can use this. So only a few heartbeats I can observe here. For samples, for 800 samples, I can see almost 4 heartbeats. Yeah, this was from what I clipped this. Okay. So here you observe, as I mentioned, the filtering. I said the filtering is very much required, and why it is required. You can see here the signal. What see you see this signal, this particular signal, the axis. Let me run it once again. You see, the baseline is on one line. So here it was tightly accessed. Okay, not moving like this. So if you observe this particular signal, your signal is gets moved on x-axis. It's something like it is wandering. The baseline is wandering. So this baseline wandering occurs due to some low frequency noise. It may be like, for example, while extracting, while acquiring your signal, due to some cause effect or the movement of patient, this may happen. This is something a low frequency artifact, and it must be removed to process it further. So let's see how to remove this baseline wander. Okay, how an low frequency signal looks like, and how can we alleviate this. So there are plenty of options available. Okay. Generally, I followed some methods which were suggested by the author, Dr. M. Rangayam, the author of the book Biomedical Signal Analysis, where you can find a lot of filtering techniques. So some of them I just applied. Okay. This is the book which I'm mentioning about. University of Calgary was worked, and now he got retired. And in this book, this is one of the fantastic books I prefer you to read when you are really dealing with some biomedical signal and all. Okay, so where you can find a lot of problems. Okay, so where you can find a lot of problems and the mathematical solutions. For them, I have written a code. Okay, so simply just I can use any derivative based method. Generally, this is a FIR filter I used. I applied on this low frequency signal. So let's first look at this. How it looks like. This is the same band baseline wonder you can observe. Okay, which I mentioned here. The signal. Okay, with low frequency aspect. So now our aim is to remove this particular low frequency artifact. And how can I say this is a low frequency artifact, as I mentioned? Let's use this as a signal analyzer or spectrum estimation using FFT, which was function which was written by me. Observe the power spectrum. If you see the power spectrum, a lot of noise you can observe in this band. Even spectrum analyzer I can use. This is one of the signal analyzer. The option is available in your MATLAB. Using this, you can analyze the frequency components of your signal. This is my time domain signal. If I want to look at its spectrum, I can see the spectrum here. There's some unwanted shootouts. I can see at very low frequency level. Okay, you further you want, you can zoom it. Okay, unwanted kind of shootouts you can observe at very low frequency. If I can alleviate this low frequency, I am expecting something which is normal that can happen to this signal. So I just apply some any low frequency, low pass filter. If I can design a low pass filter, and that will help me to remove this frequency. That's what my understanding here. And then we applied a signal, a low frequency signal here, a low pass filter signal. You see how my filter looks like, filter characteristics. If you observe that, that we will see on figure 2. But anyhow, so this is what my noise remove signal. This is what my noise removes. Here there is no baseline wandering. There is other kind of noises that will be removed later. We'll see any high frequency signal how to remove. But here you see the difference between these two. Okay. So characteristic, the rest of the things are same. We didn't disturb anything. Just we try to put this in one axis. We just try to tighten the axis just by removing some low frequency noise. And if you want for further how this looks like, just use the signal analyzer here too. Here in place of this, whatever our filtered output, let's place it here and let me run it. And now you can observe the both signals in one place, and they both particular see the blue indicates some shootout at this particular location, and now it got mitigated in the red, and the red signal is your original signal and the blue is your baseline wander signal. Both at same place you can observe, and this is how you can compare the original signal and the filtered signal both in time domain as well as in spectral domain, frequency domain. Okay, so this is how you can remove the low frequency artifact. Similarly, there is a possibility of a high frequency artifact. Generally, how it comes, like due to the power line interference in our particular India, in this situation, what type of current will come? The power is just 230 volts and 60 Hz. So generally, the 60 Hz noise may corrupt because we know, ECC is the most of the energy lies in between 0 to 50 Hz. Okay, this is what the basic characteristic of the ECG signal. And anything beyond that is generally noise. Let us understand each other. Let's understand here. So this is your high frequency noise, as just I mentioned here. Just I am showing here one segment, uh, different segments here, two segments here you can see. And this, how I say again, it is a high frequency noise. Let's understand again using your signal analysis. So this is something to remove all the windows. Now you see the power spectrum, if you observe, there is a sudden peak you can observe at 60 Hz. Okay, so this is your power spectrum. Uh, on x-axis you have frequency and y-axis you have the power, and suddenly some shoot out you can observe at 60 Hz, which is unwanted. This we want to remove. I just used the FFT concept. How can we use this FFT? Just find the FFT and square of it. That is what your magnitude spectrum, a magnitude spectrum you can find. This is what function written by me. Or else otherwise you can use the same signal analyzer function which we used here to understand the signal. So even I can also pass out this particular signal. What is the name here we have given? NECG. Let me give this to my signal analyzer and see the result. So this is my time domain signal. Let me take the spectrum. Even time frequency analysis can also be done using your STFT concept. Short time Fourier transform. Spectrogram will come. Anyhow, you see at 0.6 normalized frequency, you got this peak. So this is something wearing decaying kind of energy. You can see the most of your energy content lies in between this 0 to 0.5. That's where your maximum energy of ECG lies, and suddenly this peak comes, and this is something unwanted, and we want to remove this. Again, you can use any type of filter, and what I am applying here is a this one notch filter. Notch filter means its characteristics is just at what that point the magnitude spectrum has one low peak, and that will remove your noise. Let's understand this. See here, this is what how a notch filter magnitude response plot looks like. Here at exactly 0.6, we are nullifying that particular frequency component. When you multiply two signals in frequency domain, exactly at this location, it will be nullifying your energy at that point, and hence it will be removed with this high frequency noise. You observe the original signal. Here you see some fluctuations you can find. Here those will be removed. This is how pre-processing is an important step to get the correct results at the end. For the diagnosis, if you want to give some data to your machine learning, always you have to do this kind of pre-processing analysis, which is very much required. Okay. And later, some peaks have to be detected. The reason behind the peak detection is that they are important epochs. Using these important epochs, later I am going to show you one classification problem only solely depending on these important epochs of P wave, QRS wave, and R wave alone. I'm not going to do any complex operations, only this operation. So for that, we have a lot of algorithms exist. One such algorithm is known as a Pan-Tompkins algorithm. Okay, you can find some R peaks using your Pan-Tompkins algorithm. Here I just show you to do this. So this is an ECG signal. If you have an ECG signal, this kind of ECG signal, here I would like to see how many R peaks. Based on that, I'll get a lot of useful information. Even our last session was also happened where sleep apnea classification. Even there is a problem there. Using ECG also we can find the sleep apnea. Okay, so even in such cases, people used to find HRV. They rely on the analysis, heart rate variance analysis. For that, this RP construction RP detection is one of the crucial steps. Okay, to do sleep apnea using ECG, we very much rely on this HRV. HRV will be find out using this RPs. Okay, there is a relation between that. So hence, this Pan-Tompkins plays a crucial role. Of course, there are many other methods there in the literature. This is one of the conventional and most utilized or compared method, a state of the art method, you can say. So when I apply this particular QRS peaks, and it will return me wherever my heartbeats or there. Okay, the locations, it will give me the sample locations where my R peaks there, and the length is 32, and I can say that there are 32 R peaks that are available. These are the locations where they are exactly there, and these are the amplitudes that are associated with my R peaks. So this is what it will return me, and accordingly I will do my process. Okay. This is how I can find some R peaks, and using that I can also segment the whole ECG signal also. Before R peak, how many samples I have to place, and after R peak, how many samples I have to place. This is one of the traditional way to segment any given ECG signal. Okay, now comes to the classification. Let me go to the details of classification. There are a lot of data sets are available in PhysioNet, especially the MIT database. MI PhysioNet, you can find this MIT database. And now in Kaggle also the same data sets are available with feature extracted. Here in MIT database in PhysioNet, when you go to PhysioNet, the databases are available, PhysioNet. Physio bank is there. Previously, ATM, PhysioNet, ATM we used to call them. Now they changed the website somehow. So the data, if you take it has a lot of softwares. Those who are very much interested in doing any type of biomedical kind of research, it is one of the biggest repository where you can find a lot of data, different types of data and related softwares. And they used to put some challenges too. And there are a lot of tutorials are available on this. And this is one of the place where everybody can meet and everybody can download and do whatever the research they want, and they can apply their own methods on it. Okay. So even nowadays they are also using some GPT services, and I strongly suggest you to go through this and explore a lot. Based on your exploration, you will get the results. And you could trust this data. So a lot of open databases here. Plenty of databases you can find. Here I just type MIT DB is unit. So there are different MIT DB, but MIT BH arithmetic database I'm talking about. So this is MIT. Yeah, it went to Kandala, I think so. I'm talking about unit. MIT BH. This is what unit database. So it is now freely available and you can cite it here, and all the data related things will be given here. And when they have taken this database and how many subjects were involved and how much long it is. So you see this database contains 48-hour experts of two-channel ambulatory ECG. I mentioned this ambulatory. So they took for ambulatory and they have only two channels here. Okay, modify lead two and the other leads. There are two leads of information is available here, and it has total 47 subjects. Okay, okay, and about all the other details about the data will be given here, and it has the data like in these files 100, 101, and so on. You can find a lot of data here, and annotations will be provided for every data. There is an annotation file is also available. Okay, if this is the data and it has some annotation too. Okay. I think now we have downloaded. In the annotation, you can find at each instant of time whether the data is a normal or PVC, APC. Likewise, we have a lot of classes available for this data. So MIT BH annotations are also available. You can even visualize these waveforms itself. If I select any one of these heartbeat, you can see how they looks like. So it is like you have, as I mentioned, you have two leads. One is V5, another one is modified link to. Which one you want, that you can use. Okay, people used to mostly they use this modified lead to for this classification purpose. So you can choose your whatever the input and for how much duration you want to see them. Okay, accordingly you can see it. Okay. So this is what basically a waveform looks like. Okay, so different data you can observe for different patients. Okay, so now what I'm going to do is maybe in MATLAB also we can do, in Python also we can do, everything is okay. So let me check which one is good for us. So in Vector also I have all these things. But then most of you are now working on Python. Let me go with the Python kind of thing. Using the Spider software here. So from Kaggle, I have downloaded some data here. So here I have the data. Databases, datasets, some links over there. Okay, no problem. From Kaggle, I have downloaded some data for you, and I'm now going to process them. Okay. Here we have different types of databases, like the INCART2 lead arrhythmia database is one database, MITBH, just what you have seen, and MITBH supraventricular sudden cardiac death. But the problem with this database, I'm telling this, and already the features have been extracted, and nothing you are going to do here. Just only you can use these features and you can do this something. So for example, if I open this particular file, how it looks like. You know, these are my reports. N standard segment, they calculated all these features. Now it is no more ECG signal. I cannot plot it. For example, if I want to plot this signal, it won't show me any ECG signal because already the features have been extracted. Okay, it won't look like the signal what I have shown here. Okay, already the features have been extracted and only we can process them. Only you can do some classification and some other kind of pre-processing techniques, that is scaling or something. Only these things can be done. If you want, otherwise you want to feature extract, you do your own feature extraction and do classification. As now what I am doing is, for time being, I'm using this particular data set where already the features have been taken, and for just I'm showing the classification. Okay, this is what here, how many features you have here exactly. This is the count, 32, almost 32 features have been there. Okay, these are the labels just associated with. How many such labels are there? Let's understand them in the filter operation. Let me filter it. You can see there are 5 types of beat: N, Q, SVB, VEB, and something. What are these? Just showed here in my previous slides. Here you can see, here N represents non-ectopic beats. VEB represents ventricular ectopic beats, supraventricular ectopic beats, fusion beats, and unknown beats. These are all something was recommended by ANSI. Okay, AAMI and ANSI was recommended. A group of arrhythmias together, we call them as non-ectopic, ventricular ectopic, supraventricular, fusion, and unknown, F and Q. And these are the beats. Now we are going to classify. Okay. Now how I am going to do. The first step what I am doing here is I'm just pre-processing it. I just read the CSV file first. So for example, these are something very common to any Python programming to import the necessary libraries. So here what I am doing is pandas I am using to read CSV files and process, and also some scikit-learn pre-processing library I am taking to do some standard scalarization. Okay, I want to make all my labels. For example, you see the ranges are very much different from one column to other column. Okay, the columns here represents your features or attributes, and these are not in same range. So for classification purpose, this is the normal process we used to do to make them in same scale to process. So for that, this is the standard scaler we have used, and the process is, first I am reading the file. In this file, if you observe, what I am doing, going to take only the first n sample of rows. Means I just fixed how many samples I want to take. I fixed to 804. Why I fixed only 804? For example, you look at my file, the size, how many rows I have, more than a lakh, 1,690,000. These many, this is a very huge data to process. Now in this limited time, I cannot do this. See, already the features have been extracted, but still rows are very much high. The columns are just 32, but rows are 1 lakh, more than 1 lakh. And that is the reason why I just fixed to first 800, where I have all types of labels are available. That's how I fixed only first rows, first n samples, that is first 804 samples I am going to extract. And what columns I am dropping here, you know, the first column I am dropping. Why first column is unnecessary? First column is just indicating the record value. Then this is now no way going to influence your classification, and it is I don't want. So that I am going to remove using some data slicing. Okay. So the first column gets dropped, and then I'm separating this particular whole data. Otherwise, the rows and columns into two types. One is X is my data where it starts from here it starts. After removing my first column, this becomes first, and this is a label which we'll use at the end as a label. And my data starts from here and it goes to the next rows. And that is what from one it started, because in Python, originally the index always zero. The first index is always zero. And zero I will use as a label. It is a label information. The rest of the things are my attributes, and that's how I separated my data as X represents the data and Y represents the label information. And here the labels are some string values, okay, N, V, B, V, S, V, E, B, and all. But for my classification, I should provide them as some numbers. For that, I am using this label encoder. What it will do is my first value as 0, second label as 2, 1, third label as 1, the fourth label is 2, fifth label is 4. In such a way, it will mark it as. So this is simple encoder. Will use label encoder. Will change my data, and a standardization, as I mentioned, to change all my ranges. Okay. Once if I run this program, finally, another CSV file is going to be generated with a name called processed data.csv. Just read, write options I'm using here, using the pandas. So another file I got created in the same directory where I am working. So this is my original input I am giving. Incart2. Incart2 is the data I have given as a CSV file where I am giving a CSV file type. If you look at this, Incart2 as a if I provide, and it returns me some pre-processed processed data. If I open this processed data, you see my first this column got removed and this also removed, and from here it came, but the data is different here. It's not like 76 313 or something. It was normalized. Now you see the range -0 to +1 or somewhere the range. It was standardized according to the mean and standard deviation. I'm sorry, according to the mean and standard deviation, it got standardized. Now the range is something almost looks close, and you see the labeling. Labeling was given. My first n, all n's were given 1, and you see filter 0, 1. I'm sorry, 0, 1, 2, 3, 4, and so on. The labeling was given. Don't want to change anything to this file. Okay. Okay. Now this is what we have done as a pre-processing step. And the next step is classification. As you all know, the basic things which are involved in this classification, one by one we'll see. For again, I am taking this pandas to process the CSV file, and we have taken here model dot selection, where we can select what type of validation you want to use. Would you like to use holdout, or would you like to use stratified keyboard? First, let us go with the holdout. Okay. So here you can see the model selection. I use train test split. Holdout scheme is the overall data which we have, the rows. Okay. The rows here in pre-processed data will be splitted into two separate things. One is for training, other one is for testing. Okay. How much I want to use for test, that I will mention in my further coding. And here I am just taking different classifiers for comparison purpose. And how can I compare them? Using only some qualitative metrics. Here I'm using accuracy and some others as my metrics. Okay, from confusion matrix, I can get these metrics. And just to plot some curves like ROC, I use this matplotlib. And inside of that, I'm defining different functions. Okay, so how to plot ROC curves is just based on the results of this matrix, y test, y print, probabilities, whatever it is returning, that I'm placing, and ROC curves will be defined. And hold out how we are doing this. X and Y are the files, as you already know how X and Y were defined. Okay, X is my whole data and Y is my uh, label data, and that is the input to my fold out method. And here 20% of the data will be given for testing, and 80% of the data will be given for training at some random seed, because this separation must be always same results I want to reproduce many times, and then I must also specify the random state. Okay, 42 will always give same result. If I change this number, will throw me another result. And the classifiers with some Turing parameters. We have taken maybe number of neighbors or 5 linear SVM we are using. You can use even polynomial SVMs. Okay, it's up to you what type of, and it has to resulting in some probability values such that I can plot some curves. Random foresters, where basically the number of estimated the trees are very important in forest. I'm using some 100 trees. And then the model how we are training, I will give the train data and the test the train data with labels, and it will fit a model. And this, for this model, we will provide this test data, and it will return some probabilities when I use this probabilities. And also some metrics I can use using this. For example, you want a confusion matrix, you should give the answer y test with y prediction. Y test is the original one. Y predict is what we predicted using the model, and it just compares and returns us a confusion matrix. This is how you can do the program. Now, I providing my data. Here, my input file is the process data. If I provide this to my program, it will return me the answer. See here, my results came for different methods from beginning. If you see, this is the SVM. For SVM, I got 94% accuracy, and this is my confusion matrix. They're all diagonal entries, represents my correct classifying data, and other ones are not correctly classified data. And one of the other reasons I got the better results here, I make everything in a balanced way and used only a few rows. Okay, so likewise, many things came. Even the plots also came here. Like you can see the plots ROC curves for SVM, KNN, as well as your random forest. As this is showing your ROC. Here the two uh, positives versus two negatives. It will show some graph of false positive rate and true positive rate. This will give me, and whenever it closes to this point, if it over this graph, that means very few positive false positive rates and many true positive rates always gives us a better results. And you can extend the same concept to even tenfold. The other program I have written here is just a tenfold classifier. Everything rest is same. So instead of splitting into randomly 80-20 or 70-30 or something, some k-fold cross validation I can do. It could be tenfold or anything based on what I mentioned here. Okay. So that's all. This is about our session here. The same as I mentioned, I can even show using MATLAB also. MATLAB, we have something dedicated. You need not write even a code in MATLAB. There is an option for us here. You can see that in apps. Apps, there is a classification learner app. So here, if you provide this CSV file as an input to this, and it automatically returns the required output. Just a few changes you have to do for this CSV file. I have to read here using read table concept you have. Using that, I can read my CSV file, and I can do this process for this. See, like this, using read table concept, I can read my CSV file and I can do whatever I want some operations. So this classification learner app also easily you can use. Anyhow, it is okay. Let's only fix with this spider or Python with this. Maybe another kind of time we will explore some other tools too, like MATLAB, Vecca. How can we use them? Maybe go with another kind of session. And that's all from my side for today's session. Thank you. Any doubts from the participants? And yeah, Raman sir, thank you very much.
So some chat box questions. The practice purpose provide this template code. Shankar is asking.
Yeah, okay, sir. It's fine. We can provide it.
Thank you, Dr. Rajesh, for wonderful session.
Thank you, sir. Can I stop my presentation?
Participants, any questions? In spite of a busy schedule in the evening also. They are asking for material, sir, PPT. So please share the PPT so they can.
Yeah, it's kind of a general concatenation from ECG SPOT. You can do it in different ways. If you want them to use, you can just use the general concatenation rows as columns. You can merge them. But for all signals, you have to do in the same way. Then all features you can use it for further classification.
Okay. Okay, thank you, Rakesh. Thank you, Rajesh sir, and participants for your patient listening. Have a good night. Bye. Thank you, sir.
Okay, thank you. Thank you.